All right, we're going to go ahead and get started. Welcome everyone to our academic seminar series today from the MANNA Institute at MANNA in Philadelphia. Today we welcome Dr. Kristin Rising and Mackenzie Kemp, who will be discussing their research on patient-centered outcomes to access nutrition interventions. The agenda of today is that I will present a short introduction to the seminar. My name is Julianne Henstenberg. I am the director of the MANNA Institute. And today I'll tell you just a little bit about the Institute. And then we'll have our seminar presentation by Dr. Rising and Mackenzie Kemp. And then we'll follow that with question and answer session to answer your questions from today's presentation. And please do submit your questions today in the chat, and I will moderate those and ask our presenters. So I want to tell you just a few words about the MANNA Institute. The MANNA Institute is the research and evaluation arm of MANNA, and we explore the impact of nutrition on health for people with serious illnesses. We are a medically tailored meal provider and nonprofit community-based organization. And our arm of MANNA leads research and evaluation initiatives. We also educate healthcare practitioners and consumers, and we share our findings and best practices for improved service delivery and healthcare transformation in the space of medically tailored meal and nutrition service providers. We are at the end of celebrating March as National Nutrition Month, and this is an effort of the Academy of Nutrition and Dietetics to share latest nutrition information and tips for professionals and consumers. The theme this month is called Fuel for the Future. And the activities at MANNA over this month have been supported by Bimbo Bakeries and PA Health and Wellness. So today our speakers are going to talk about their research at Sidney Kimmel Cancer Center at Jefferson University here in Philadelphia. Their research looked at what patients are hoping for as outcomes related to nutrition interventions. So they'll talk about their findings, as well as how they're using their findings to build new tools to use to assess what types of nutrition interventions and what level of nutrition support is best for patients undergoing cancer care and treatment. Our first speaker today is Kristin Rising. Dr. Kristin Rising is the executive director. Excuse me for a second. Dr. Rising is a professor and director of acute care transformations in the Department of Emergency Medicine at Thomas Jefferson University. Her research goal is to develop evidence-based practices for providing compassionate care focused on addressing each individual's psychosocial and medical needs. She's led grants from numerous foundations, including PCORI, AHRQ, and the NIH. Her current research portfolio focuses primarily on addressing patient uncertainty related to seeking care and developing novel approaches to reduce the impact of social determinants of health, including food and digital literacy, on individuals' health. She's been on multiple national expert panels, including being an ongoing member of the Centers for Medicare and Medicaid's expert panel for quality measurement, and is on the editorial board for the Annals of Emergency Medicine and Academic Emergency Medicine. Our second speaker, Mackenzie Kemp, is manager of the Center for Connected Care at Thomas Jefferson University. Mackenzie Kemp is she supports the development and implementation of operational, fiscal, and administrative policies and systems. She also supports the center's nutrition-based research portfolio. She's trained as a program evaluator and completed a dual master's degree in social work and public health at Washington University in St. Louis. Welcome, Dr. Rising and Mackenzie Kemp today, and thank you for being with us, and we look forward to your presentation.
Thanks so much for that introduction. It's truly my pleasure, and I know Mackenzie's as well, to be here today and to talk to you. Our nutrition work that we do is some of my nearest and dearest within the center, so thrilled to be able to talk about it today. So I'm going to start sharing my slides now, and give me a moment here. All right, so as Julian introduced, we're here to talk about kind of our work around thinking about patient-centered outcomes to assess nutrition interventions. As she mentioned as well, I am an emergency medicine physician at Jefferson, and as well as the director of the Jefferson Center for Connected Care. We first want to acknowledge a few key people and groups. So the MANNA Institute here, which funded the work that we'll talk about specific for patients with cancer in the latter portion of this talk. Also want to thank the following team members from the Center for Connected Care that you can see here who were involved in the work that we're presenting today, as well as some additional thought partners that you can see who have been involved in various aspects of the work that we'll go through. So the Center for Connected Care, just a moment to talk about. Really, our mission is to tackle pressing patient-identified issues to create a more connected system of care. All of the portfolios we work on have been identified in early qualitative work with patients, asking them kind of what's broken about this system, this health social system, and what do we need to do and work on to make things better and to make you able to kind of achieve a better state of health at home. Our vision is to create a healthcare system where patients are the drivers of their own care and well-being. So we do have a couple of various portfolios. We'll be talking about our food as medicine work today. We also work on digital health readiness, in rapidly increasing portfolio focused on harm reduction for people who use drugs, work on telehealth as a means of alternative care delivery models, and then have had quite a bit of work going on these past few years since the onset of the pandemic to focus on increasing vaccine confidence. Today, though, we're really focused on that nutrition work. It's relevant to you all. So for some background, I'm going to give a little bit of where this came from. So what our prior nutrition-related work has been and kind of how the next things fit into that work. We'll talk about our current work in which we really are wrapping up that work focused on nutrition goals among patients with cancer. Then we'll talk a little bit about what we see as the future moving forward that is important to really help figure out how we can best connect patients with the right level and amount of nutrition support. For background, I don't know all of you on here, but I suspect that most of you in your work are aware of this to some level or another. Diabetes is a very common and lethal condition. So diabetes mellitus, these are stats from a few years ago now, but are only worse if anything. So about 9% of the population has diabetes. This is increased when you look at populations such as African Americans. And in Philadelphia, actually, stats from a few years ago were that 16% of adults and just a little over 20% of African American adults had diabetes. It's the 7th leading cause of death in the United States. African Americans and patients with lower socioeconomic status are more likely to have poor control with diabetes. And poor control really leads to significantly increased risk of complications. So we found, right, hemoglobin A1C, the primary metric of control. For every reduction, the lower the A1C, the better your control is. For every reduction in hemoglobin A1C by 1%, we see a 35% reduction in risk complications. So really helping patients to achieve control is essential for reducing the risk of complications. So diabetes is actually a condition that we know in the medical system, we have pretty good tools to control that. It's complicated though. It's a process that takes a lot of engagement with patients and also often multiple meds and a lot of management. And so despite having appropriate approaches to control it, only about 57 people with diabetes have what's kind of medically thought of as adequate control. And so our team years ago, this was probably 8 years ago or so, we undertook an initial process to look at the why. What was happening with these patients, and specifically for patients who were coming to the healthcare system, why did we have such bad outcomes still? There was clearly some misalignment in terms of what patients wanted and needed from us and what we were able to be giving them. Really, right? So we thought patients have unmet needs related to their diabetes and we ought to look into those. So our very initial work, which led to this whole nutrition portfolio, was conducted with funding from the Patient-Centered Outcomes Research Institute. Was focused on these patients with diabetes and those who had a hemoglobin A1C over 8. And generally, we would all consider these not sufficiently controlled outcomes for diabetes. And our question with this work was looking at the primary needs or goals of these patients related to seeking care. We engaged close to 150 patients. We did 89 interviews. So this was a lot of interviews because we wanted to capture patients in all different parts of the kind of settings of care. We interviewed patients in the emergency department, in the hospital, in primary care visits, and we engaged groups in brainstorming sessions to think about what are all the things that you need or want related to your diabetes care. The top goals that we heard outside of just, I want better diabetes control, were heavily focused. I need a better understanding of nutrition, right? We heard a lot of the health system's really good at telling me what not to eat, but no one's really telling me what to eat or how to do it. And so I just feel kind of lost and overwhelmed. And so I'm not even going to try. And I need kind of a better access to healthy food and better eating habits. And these were some of the specific things we heard were the access and affordability, the education we talked about, and then less common, but still things we heard were issues of tradition and culture, right? Learned lifestyles in terms of how I eat, social pressures for eating certain ways, and kind of time limitations for doing what was kind of, healthy. And so these were some of the things we heard. I always feel like a few quotes are so helpful for understanding patient context, right? So on the access side, in my neighborhood, there's nothing but pizza and burger places. People are working 2 and 3 jobs. People are single parents and raising families, and the cheapest food is junk, right? That's what people can afford. We eat what we can afford. Would I like to eat fresh broccoli every day and a fresh asparagus? Yes, I love it. Can I afford it? No. So access was a big component. Education as well. And some of these quotes were so powerful to me. I don't know if I'm not eating enough of vegetables. I don't know if I'm eating too much starch. Then the doctor tell me no starch, no this, no that. I don't know what to eat. I'm scared to eat. Right, another one here. I'm getting different information. I speak to my doctor, I speak to nutritionists, I speak to the nurse. Everybody's contradicting themselves, right? And so I'm so confused right now because it's just everybody's sending me in a different direction. Next one as well, which you can see the amount I eat. Can I have bread? Can I not have bread? Is it natural sugar, right? Just so much confusion, which makes sense in kind of all the different places that people can get messaging these days. And so we heard this early work. The access and education came out really strongly. So we said, okay, these are the most prevalent things that people are telling us we need that we can do something about, right? And we started looking at kind of what exists as options for patients. And this is where we came out really with 2 things. We said, well, medically tailored meals exist. They certainly have been designed with that education component wrapped in, right? And are focused in addition to bringing the meals to people. And medical nutrition therapy, right, is a specific focus on education. These are things that are developed and already within the medical system for certain individuals. And so we started to look to these to think about how could we think about designing a program that we could integrate things like medically tailored meals and medical nutrition therapy for patients. You all probably know medically tailored meals. We're here with the MANNA Institute, but these are meals delivered to individuals living with severe illness, right? And so these patients with poorly controlled diabetes and having a lot of poor outcomes related to them certainly fit within this realm. They're tailored to the medical needs of the recipient by a registered dietitian nutritionist. And they're designed really with the goal of improving health outcomes, lowering the cost of care, and increasing patient satisfaction. So we looked through, and I'm not going to run through these all today for you in terms of what the evidence looked at, but we looked in detail to look at what the evidence showed for medically tailored meals. And what we found mostly were there were multiple studies looking at the impact of them. But these studies were in general smaller studies or looked at kind of short time periods. So these pilot studies did find that medically tailored meals seem to reduce healthcare costs. They seem to reduce healthcare utilization, and they appeared to reduce hemoglobin A1C for patients with diabetes. What was needed next, though, and pretty clearly identified both in those studies as well as by our team, is that randomized trials were needed, things that we could really look at hard data about kind of the impact of these meals and a focus on sustained impact, because that's really what we start to care about for patients is you can change something for a few months, but can you actually change the trajectory long enough to impact their health outcomes? And these things are vitally important to then think about the ultimate goal, which is to get medically tailored meals and other interventions covered routinely by insurance so that patients would have access to these more regularly. So medically tailored meals, we said there's good promise, but we need some more data here. For medical nutrition therapy, again, this is a component of usual care. It's just not something that most people receive as part of the care. And some of that is from limited insurance coverage. And some of that is from a lot of barriers for patients in terms of being able to actually make it to these appointments in addition to all of their other healthcare needs and life needs. Medical nutrition therapy is individually tailored nutrition education and counseling. It involves significant focus on behavioral activation, right? Helping people to actually integrate into their own lives, their own activation for managing their nutrition. And it is actually a recommendation from the Academy of Nutrition and Dietetics that all individuals with diabetes be referred for MNT, that they get 3 to 6 sessions in the first 6 months, and then that they get follow-ups, acknowledging that people with diabetes do need this education. When we looked for the evidence for MNT, again, we found individual studies that did suggest improved outcomes for people who received MNT, actually both via phone and telemedicine. These were things that were developed really to overcome some of those barriers to in-person visits. Systematic reviews, though, really found that at the point when we looked at this, and this was back some years ago now, that there was lack of sufficient evidence on MNT for ultimately how it impacts glucose control. And that really there was a need for more data. And so next steps coming from here, we said, okay, MTM has a promise to address the things that our very patients are telling us they need. They need access to healthy food and a food that is appropriate for their diabetes, but we need more data. And so we wanted to look at cost effectiveness data, right? Because that's how we get this integrated into insurance. We wanted to understand long-term effects and make sure also that there aren't any adverse effects to people getting medically tailored meals. Do we take away a bit of self-efficacy when people get their meals for a few months and then they have to start cooking again? So really understand what that long-term impact is. And then for MNT, we needed more rigorous data overall. And so that's where a trial that we're running now came from. This trial is called Project MINT, which stands for Project Meals and Nutrition Therapy. It's a trial that's funded by the NIH, specifically from NIDDK, and started in July 2019. So this is a rigorous randomized controlled trial that we are running, where we are ultimately randomizing 600 patients with diabetes during an emergency department or visit or an inpatient hospital stay into one of 3 different arms. So they're all getting randomized, 200 of them to their continued usual care, 200 of them to 12 weeks of medically tailored meals that are being delivered by MANNA, and the third one to 12 weeks of medically tailored meals, as well as a telehealth delivered nutrition education intervention. We chose the telehealth delivered specifically because we wanted to make sure that this was as accessible as possible to people and had as minimal interruption on their lives so that we could have ideally improved uptake. Our ultimate goal with this work is really to look at the kind of the impact over the course of an entire year. So we're assessing effectiveness of both of these interventions compared to usual care in reducing hemoglobin A1C at 3, 6, and 12 months. 6 months is the primary outcome we're using to look at kind of overall efficacy, but we are getting data at each of those time points. And then we are specifically doing a cost effectiveness analysis of these interventions, because the ultimate goal of this work is to inform provider and payer decisions regarding the recommendations, offering, and covering of these services. We really want to get these services integrated at a higher level into care options for patients that are covered by insurance. And then to really help also think about how these services should be structured for scalability and integration into kind of larger care delivery systems. So, this has been a really important project for us, and we really feel like has a lot of potential to impact kind of healthcare delivery in the nutrition space. And the discussions that we were having with folks, including MANNA folks, was how do we expand to other chronic diseases, right? This is really important data we're going to have for patients with diabetes, but let's look at expanding to a next condition. And cancer was one that came up as particularly important, right? So we think about patients with cancer, they've got very high nutritional needs, and they've been really a primary priority population for MANNA because of that, despite the fact that in general, this is not covered by insurance, right? So it has been something that MANNA's really said, this is important for us to do. We could really use some better data on this though, so that then we can look at kind of the coverage and benefits. And we said, great, let's do another trial with patients with cancer. But we were stuck at a really important problem, which is what we've been working to address now. For diabetes, as I talked about, hemoglobin A1C is a well-accepted metric of overall diabetes control, as well as something that's intimately linked to nutrition. So it was an obvious primary outcome to be looking at. But for patients with cancer, there's really not an obvious nutrition-related outcome that's a primary cancer-related outcome. And so we really stopped to think what would be a meaningful patient-important outcome for us to use as for a study, right? And when we think of patient-important outcomes, this scenario just like hopefully kind of helps give you that context. But we really think that patients have different needs in their life and different ways that their health impacts their life, right? And that's going to be really different when you think about different patient scenarios. So think of Sarah B., a 52-year-old woman who was recently diagnosed with breast cancer. Her chemotherapy treatments have left her with significant nausea and mouth sores, and she's lost 10% of her weight since her last visit. She's tried to supplement her meals with Ensure, but it isn't enough. She doesn't have the energy to cook her meals and still manage all of her other life duties, and her work performance has suffered recently as a result. Her social worker made a referral for her to MANNA. While Sarah's care team is primarily concerned about ensuring she does not lose more weight, Sarah's primary question is this: will the meals allow her to have the sufficient energy she needs to regain her performance at work? Right? And so ability to perform at work or ability to maintain daily life activities might be the thing that Sarah says, I really need to capture this. And if you can impact that with my intervention, like that is going to tangibly be the most important thing to me within my life now. And so this leads into our kind of nutrition goals and cancer specific study. I'm going to turn this over to Mackenzie at this point to continue. I'm maintaining the slide, so apologies if there are any kind of poor transitions here, but I'll do my best to keep up with her.
Thank you, Kristin, and thank you to the MANNA Institute for having us today. My name's Mackenzie Kemp. I have had the honor of being involved in the Project MINT study you just heard about, as well as our work with patients with cancer. And through both of these projects, I've also gotten to engage with the wonderful staff members at MANNA and the MANNA Institute. So thank you to you all for having us today. When we think about our work with patients with cancer, we had two primary aims. The first was to identify those patient-important outcomes related to receiving nutrition interventions during cancer treatment, and then using those patient-important outcomes to develop a measurement tool to evaluate the success of nutrition interventions during cancer treatment. Our study had three main phases. First were patient and clinician interviews, where we were really eliciting those patient-important goals and outcomes. We then used that data to inform a draft measurement tool. And then finally, we did a pilot test of the measurement tool with a population of patients with cancer, just to understand if this was getting the type of information we expected. So when we think about the population who participated in the patient interviews, we spoke with 31 patients at the Sidney Kimmel Cancer Center who were currently receiving cancer treatment. And in order to get a variety of perspective, we were interested in speaking with patients who were at nutrition risk. And we defined that as a patient who had a score of 2 or higher on the malnutrition screening tool, or MST. And we were also interested and thought it was really important to get perspective from individuals who had self-reported food insecurity. And we defined food insecurity as responding often or sometimes true to the USDA 2-item screener. So ultimately, 14 of the patients had nutrition risk, but did not report food insecurity. 7 were at nutrition risk and did report food insecurity. And then our third population were individuals who had received MANNA meals in the past 6 months, regardless of their food insecurity status. In terms of demographics, we actually spoke to a pretty wide age range. We spoke to people from 25 to 81. Half of our folks identified as female, a little over half as Black or African American, and 45% were retired. For the clinician population, these were all clinicians at the Sidney Kimmel Cancer Center. And It was a variety of providers, dietitians, head and neck cancer specialists, medical oncologists, radiation oncologists, social workers, and a supportive medicine nurse practitioner. So on the next handful of slides, I'm going to go over the primary findings from the interviews, and I'll also be reading a few quotes. So when we asked patients to talk about the impact that cancer had on their usual food and nutrition habits, almost every patient just affirmed that cancer really did have a significant impact on their nutrition-related needs and habits. And when they talked about this impact, what really came out was the impact of the symptoms they were feeling. So the patient said, I'm eating much less. I've lost a tremendous amount of weight. I was nauseous, exhausted. My total taste was altered. The second main theme that came up was patients' ability or challenges with doing daily food-related activities, things like going to the grocery store, preparing food. So when they talked about their ability to do daily food-related activities, we heard the salads, you have to clean the lettuce, the tomato, you have to clean all that stuff. And I just don't have the energy or the gumption to do all of that. I do try to go to the store, but a lot of times between the cancer and the treatment, it kind of just tires me out. It drains me. With my body fatigue and everything, it's not where it used to be, my energy level. And lastly, this wasn't a theme for all patients, but for some of them, they really did highlight the important role that caregivers or social support played in ensuring that they had adequate nutrition during their cancer journey. So these quotes to me were just really important. If I didn't have my partner to literally have food there for me, I wouldn't have eaten. My sister moved in with me. She's a nag, so she reminds me to eat and she'll make stuff for me, but the will to eat just isn't there. So now switching gears a little bit, instead of looking at just the overall impact of cancer on nutrition, we also asked patients and clinicians to talk about how they would determine if a nutrition intervention was successful for them. And maybe unsurprisingly, the item that rose to the top for both patients and clinicians was seeing weight gain or maintenance. So patients said, to gain a healthy weight like I used to have, and I'm not worried about it because I think about it all the time. Another indicator of success, which I hope we all feel in our daily lives, is just being able to eat food and get satisfaction from those meals. So the patients clearly just enjoying meals and eating them was a big indicator of success. And from the clinician perspective, a patient reporting that they now have enough food, they feel like they're having adequate intake. Thinking more about the emotional impact of cancer on a nutrition needs, a lot of patients talked about how much time they spent just thinking and worrying about food and their nutrition. So a success to them would be less time worrying about this. I never thought this much about food. It takes up too much of my day. I could focus on how I felt and trying to get myself better, and I didn't have to worry about what I was going to eat or drink. And finally, another big theme was just having increased energy to do those daily activities and every other thing in life that people enjoy doing. So the first patient is actually talking about the MANNA meals. It gave me more energy because number one, it didn't take too much to eat and prep it and stuff like that. But it gave me more energy because I felt like I was on the healthier side. And a clinician, everyone's going to get tired, but how well have they recovered? Are their energy levels recovering faster because they have adequate nutrition? So just to review, some of the major findings around the impact of cancer on nutrition were symptoms, challenges with daily activities, and the important role of social support. And then the main indicators of success: increased weight, increased food consumption, less time thinking about food, and increased energy. So when we were thinking about how these findings would translate into a measurement tool, kind of the main domains that nutrition interventions could impact included symptoms, food-related daily activities, and really just generally the physical and emotional toll that the cancer journey has on patients. So now we move into phase 2, which is the tool development. In order to develop our measurement tool, we generated questions or items to represent our main interview findings. Along the way, we also consulted some survey development experts here at Jefferson. And then we conducted 18 cognitive interviews with patients, really to refine the tool and make sure we were asking the right questions, covering the right topics, and making sure that we were measuring what we actually wanted to measure. So the types of questions we asked or topics we covered in the measurement tool, again, assessment of symptoms and activities of daily living, use of nutrition services, we asked about food insecurity, we gathered demographic information, and we also asked for patients to report their cancer type and treatment status. We actually wanted to just use this slide as an example of one of the questions we asked, but I also want to highlight that in our cognitive interview process, we spent a fair amount of time identifying the best scale to use when asking about these questions or asking these questions. And specifically around symptoms, patients really identified most with the word problematic instead of words like stress or concern. And then the following question around activities of daily living. Again, patients actually preferred the word concern when they think about their limitations or challenges around doing these food-related activities. So I thought that was just a really interesting finding from the cognitive interviews and what this emotional process is like when patients are thinking about symptoms and activities of daily living. So phase 3, pilot testing. The survey was sent to patients from the Sidney Kimmel Cancer Center who, again, were at nutrition risk, as well as individuals who had received MANNA meals in the past 6 months who also had a cancer diagnosis. They did not have to be patients at Jefferson, so we got a broad range of perspective from that population. And to give you a sense of what the survey sample looks like, 40% of the survey sample had reported ever receiving MANNA meals. A little over a third had reported food insecurity. And then our average age was 62 and primarily white and female. When thinking about the feasibility of conducting assessments with this population, one of the bigger lessons we learned was the best way to reach patients. So we did 2 rounds of recruitment. The first was a paper mailing. So physical surveys went out in the mail to the SKCC patients as well as the MANNA recipients. Those participants had an option of completing the survey on paper and sending it back, or using a QR code to complete the survey online. 45% of our sample responded to the paper mailing. Our second wave of recruitment was actually approaching patients who were at the infusion center at Sidney Kimmel Cancer Center and asking them to complete the survey individually on an iPad during their infusion treatment. And 55% of our total sample ended up coming from that recruitment. So I think an important lesson learned was paper surveys over QR codes were incredibly important. Almost no one used the QR code, but then the infusion center really provided a nice setting to reach patients and also have conversations. We did our cognitive interviews there as well. So that was a nice lesson learned. With the paper surveys, I just want to acknowledge that that does come with some challenges around missing and incomplete data. So when we did receive paper surveys that were incomplete or missing some information, we did do our best to follow up with those participants to gather the information over the phone. For preliminary analyses, we used chi-square tests to see if there were any significant relationships between select variables of interest. So we were interested in seeing if folks who had ever received MANNA meals had different outcomes. And we did see that those who had received MANNA meals reported higher levels of concern with going to the grocery store, paying for food, preparing meals, and managing their weight, compared to those who did not receive MANNA meals. And when we see this, I think it's a nice acknowledgement that MANNA is really reaching a vulnerable population that has a variety of needs. And those needs, things like preparing meals and going to the store, may not have been filled within the traditional healthcare system. Next, we did a little exploration into food insecurity. So those who reported food insecurity reported higher levels of concern with going to the grocery store, paying for food, preparing food, and sharing mealtime with family or others. The sharing mealtime with family and others is an interesting, unexpected finding. We weren't able to gather any nuance or further detail around this concern and why it's a concern, but I think we would be interested in exploring this further to really understand what the core concern is there. And lastly, those who completed their cancer treatment reported higher levels of concern with paying for food and preparing food compared to those who were still in treatment. And I think this is really important to highlight that folks definitely have various nutrition needs during cancer treatment, but nutrition support may be needed into survivorship as well. And I just wanted to acknowledge that we did look for any relationships between the receipt of MANNA meals, food insecurity, and treatment status with symptoms, and there were no significant relationships found. So again, to me, that really emphasizes the really big role that some of the emotional and like activities of daily living, those limitations play during cancer treatment. So some of our key takeaways is that MANNA is reaching a high need population. Nutrition needs extend beyond the treatment phase, and needs are different for every patient, and they may change over time, which kind of leads to the last key takeaway, that nutrition is multifaceted and it really does require individualized approach and really kind of a nuanced understanding of exactly what needs a patient has and what support they think would be best for their situation. So moving forward, our team is interested in validation testing of our measurement tool among the cancer population. We think there's still a lot more we can learn since our initial sample was only 117 patients. We would also like to see the extent to which we can detect change over time in this tool to see how needs or outcomes change. And ultimately, what we're really excited about is developing a process to identify a best fit intervention for a patient and step down services. So when I talk about best fit and step down, Kristin, you can go ahead and click. Thank you to the Food is Medicine Coalition for this graphic, but what we're really thinking about is how a patient may move along this pyramid over time. So a patient may start with receiving medically tailored meals from MANNA, but maybe they don't need that for their entire cancer treatment or cancer journey. So how can we as a healthcare system and social service network really be able to measure and understand when someone may be ready to step down to a different nutrition support? And I think for our team, when we think about like patient-centered care, another aspect of this is really just what does the patient think is best for them? When they consider all of the supports and challenges they may be facing around nutrition, what do they think is really going to make a difference for them? In closing, while there are definitely shared experiences among patients when they think about nutrition during cancer treatment, we also like to acknowledge that this really could be an individual journey, and everyone is facing different challenges and has different supports in their lives. So individualized nutrition support is definitely needed. We are going to continue exploring the impact of nutrition during cancer treatment and assess change in needs over time. So thank you so much for joining us, and we are happy to take questions.
Thank you so much, Dr. Rising and Mackenzie. That was a fabulous presentation. So I'd like to ask the audience to put any questions in the chat right now. And I'll start with a question or two while people are doing that. I knew a little bit about this research, of course, but I'm very interested in how patients reported to you their indicators of success. I found those results really fascinating. And so I have kind of two questions around that while people put questions in the chat. One is, you mentioned with your tool and you looked at differences between those who are food insecure and those who are not. And I know you only had a really small number when you were doing the interviews, but did you have any feelings for whether people who are food insecure or not had different indicators of success, or was pretty much everybody saying the same thing?
I think the indicators of success were pretty shared across our different patient subsets, but I will say, when asked like what type, if nutrition support like medically tailored meals would be helpful for folks, those who had reported food insecurity were more likely to say, yes, that sounds like it would be helpful to me, while maybe some of the other patients said, I don't think I need that level of support. I have my sister cooking for me, my child cooking for me. So I think food insecurity rose up most significantly when thinking about if medically tailored meals would be helpful for them.
Thank you. And this is a bit of a philosophical question, but I know you guys are deep into this. I find that patient-reported outcomes and related tools are potentially really useful for us here in community-based organizations as not only outcomes tools, but effective tools for how to also help people step down who are on a program. Is this something that is the results of the, is this something that is being considered in healthcare as outcomes that they will consider important in the future, over and above some of the outcomes that are standard now, like some of the process variables that you'll see that, here in community-based organizations, we don't have any control over necessarily, or even lower costs and healthcare utilization, which are so important in the outcomes world, right? So do you see patient-reported outcomes as being important right now, or even just becoming more important in the future? Because I really feel like if people are reporting what they need and getting that they're going to do better at the end of the day. So how do you tie that to an actual thing?
Yeah, no, it's a great question. It's complicated, right? Yes, I see there being increased interest and increased focus on how to incorporate these outcomes. And I do want to tease out the term, they're often go together, but patient important outcomes and patient reported outcomes. So patient important outcomes are often also reported by them, but don't have to be, right? Sometimes, and some patients may say, my most important outcome is that my hemoglobin A1C be reduced, right? Or that some other, or my weight, right? Weight is one that we use in healthcare and they use. So patient important is really just the important. And importantly, on the flip side, patient reported outcomes, a lot of people say like we're being patient-centered because we're using patient reported outcomes. Patient reported outcomes aren't necessarily things patients care about. They're just literally things they're asked to report on. And so there's a sweet spot of, for those, finding the patient important and patient that are patient reported for truly, you know, patient and important and reported. Just like a little bit in there, because I feel like the clarification is important because a lot of people just use the report and assume it's important for patients. So I think the challenge we have and that we work on from the kind of research and gathering evidence side is to find outcomes that are important to patients that either dovetail then with still the kind of medically accepted important outcomes that can be at least measured and demonstrated to the healthcare system. Yeah. Or that we can, and those often get tied, right? When you do cost effectiveness, you have to base the effectiveness on something, right? But if we're looking at measuring a patient important outcome and saying that we are improving lives from the patient perspective, and then maybe we take an outcome that the medical system cares about, but the patient doesn't necessarily as much, and can do some of our cost effectiveness work in that to show, hey, providers and insurers, we're actually reducing the cost of care based on the things you care about, and patients are happier and doing better. Like that's the ultimate win that we can find. And so I think working on those, working in those areas and trying to find those spots is tricky, but not impossible, and is increasingly where we're focusing on this, as well as in developing tools that hopefully can be simple enough sometimes for patient important outcomes to be able to integrate them into things that we're starting to capture in healthcare encounters and not just in our research. Okay. There's still a ways to go in that area though.
Well, thank you. Thank you so much. That's fabulous. So I'm going to give you some of the questions now in the chat. Let's see. Okay. So here's a question. Have you done any post hoc analysis separating those with physical causes of low energy, such as anemia, for more psychological causes related to activities of daily living, to see if MANNA meals may be more effective for physical causes?
It's a great question. I was reading those a moment ago in the chat, and Jennifer, thank you for that. So we haven't done, this was a small enough group that kind of extra analyses such as these and the level of detail that we have on them just don't exist now. But I think all of these and comments from you all and suggestions as we start to think about where do we go next and how do we start to tease out some of the important areas for people, it certainly is a great question. And I think that looking at those, physical causes are going to be important to tease out.
Fabulous. So someone said, thank you, tremendous work. Have you asked or assessed taste and smell function in any of your work? 50% of diabetics experience some degree of smell loss, and many cancer patients have taste smell dysfunction. Understanding this could help tailor solutions that are adhered to.
I may give a somewhat similar answer in the thank you for the suggestion. I think capturing that when we are getting a broader range of kind of the background of the patients that are engaged is important. Certainly, and like tailoring the interventions, it is a whole next level, right? And I'm kind of even curious from the MANNA side if any of those factors weigh into kind of how you design approaches for patients, because I do think that taste and smell, we do increasingly acknowledge, has been talked about a lot more since COVID hit even, right? People thinking about like, oh gosh, loss of taste and smell, but how that impacts lives moving forward. And we see more of that as a chronic challenge for people will be important to increasingly focus on understanding.
Yeah. I know some of our own dietitians are on, but I don't know how to turn them on in the presentation mode. So I'll just give a general answer for what I know. And I know that our dietitians, as you know, do work with our clients individually. And I know they give them suggestions for using spices and other types of things to do taste profiles. We also assess whether people like our meals and get suggestions back from them. So we do sort of change to the types of client populations we have. But since we do produce an enormous number of meals, we can't exactly tailor to the individual at this point in time. So, but I do know our dietitians work on that, and in terms of food consumption and helping with that.
We definitely heard about change in taste in our interviews, which no doubt impacts someone's satisfaction with food and just like will to eat. So that definitely came up.
Let's see. Do you see any traction with CMS adding this to the list of covered MNT? It has always felt unfair that insurance covers aggressive MNT for end-stage renal disease or dialysis, but not oncology. Most places I worked, the inpatient RDs would provide free counseling to the patient with outpatient oncology, but it was difficult at times to manage the additional caseload on busy days.
That's an interesting question. I don't know specifically. It's fascinating to me, and I should look into, or if you know, Jessica, after, maybe you can share with me after this, the background to why and how the kind of renal patients have ended up being covered so aggressively and not within oncology. For the coverage, I will say that this moving into the cancer space and kind of understanding that nuance has been newer, at least to our team. So we've spent a lot more time kind of diving in on the diabetes side, but clearly we have some more kind of learning and work to do there to think about if we can replicate some, right? How did we get there with renal disease? Then that can help inform sometimes the path for how do we get there more with other conditions. And so that would be a helpful part of what we look at as we continue to craft the, questions and design of next work.
Great. These next two are requests to collaborate with you, but I do want to welcome Monell Center today. Thanks for attending, and also a professor from Drexel University. I personally am really happy there's a lot of crosstalk going on, and the MANNA Institute really supports that in terms of finding the nutrition people in Philadelphia and working together. And here's another question. This was great. Again, I'm wondering if Jefferson MANNA has done any research around fruit and vegetable prescription programs versus the pre-prepared meals, or as a step down to get people off the meals and back into the grocery stores. So we have not done research on fruit and vegetable prescription programs, but there is a center. If anybody knows it, please put it in the chat. It's at the University of South Dakota, I think, that is looking at all the research on fruit and vegetable programs within the SNAP program. And they have a really lot of research there. But does anybody know of any that is being conducted locally, or are you guys doing any of that?
Sorry, I was trying to pause for Mackenzie, but it's like, this is like the nearest and dearest to what we think about. So Sophia, you are like falling right into the area that has become kind of a prime focus in kind of my and our thinking that we're looking at developing out, is like just stepping back and thinking about the whole picture, right? And going back to that food pyramid. And importantly to me, really developing an approach that we think much more holistically about people's socially driven needs and people's medically driven needs, and that we stop sending people with medically driven needs to dietitians and socially driven needs to social workers, because almost nobody has that clear cut a situation. And there's like immense overlap and interplay between those. And so I think at any one point when we think about, let's assess your social environment and your medical needs and figure out that level on the pyramid that you fit, and then think about monitoring occasionally to see, occasionally someone's going to move up the pyramid, right? And then I got acutely ill and I need a little bit more. And so how do we get you the little bit more and then bring you back down when you're doing better? And how do we ultimately then, as people are on the pyramid, think about moving everyone down, right? So lower intensity and eventually kind of off the pyramid potentially. And so we've been doing a lot of work to think about how we would structure a process to systematically individualize that, that referral, because I think that's the only way that we can do it in any sort of large fashion, is to have a fairly, robust logic model to what we're doing and just kind of plug people in as a starting point and then do some refinement as we go. And so there's not work that I know of that's looked at that. There is work that, people look at specific interventions. It's not always the MANNAs of their area. So, as we looked through things, people looked at fruit and veggie delivery for patients with diabetes or other folks, and then, looked at outcomes, but there hasn't been anything in a larger rigorous process, and certainly in the step down of how we, move people across the pyramid.
Yeah, absolutely. Thank you so much for those ideas and thoughts. There's also a comment that, unless anybody has any other questions, I'll just add this in as a kind of a closing thought, but I know this person, and she says that for those who live in a food desert, a congregate meal site from the area office on aging provides lunch for a free will offering. Example, PCA, Philadelphia Corporation on Aging, has about 24 congregate meal sites. Other counties have similar, and I personally know that across the state of Pennsylvania, I used to consult for some rural counties, and they are all across the United States. And that is definitely a possibility for those over 60 who have access to those things and have the physical abilities actually to get there. But it is a great step down for that set of the population. So, are there any other closing thoughts or questions? If not, I'm going to thank Mackenzie and Dr. Rising today for such a fabulous presentation and so many great thoughts. And as they said, please contact them if you have any other additional thoughts or want to connect or provide them with some suggestions in the future. Thank you again so much, and thank you everybody for attending today.
Sure, thank you.
Take care.
Bye.
Bye-bye.